So good morning, everyone. Thank you for being here and for providing me the opportunity to present a little bit about quantitative magnetization transfer. The goal of today really is to kind of give a little bit of an overview about some current techniques that are in the field, maybe back up a little bit and even do a little bit of education about what is meant by magnetization transfer and quantitative magnetization transfer. It's not going to be a true historical survey, and we can't possibly cover the number of pathological opportunities for MT, but I hope to give you just a brief flavor of that. I have nothing to declare. So first question is why in the world are we talking about magnetization transfer at 8 o'clock in the morning on Sunday in Montreal? The reason is that when we think about magnetization transfer in the central nervous system, there are many other applications beyond that. But we think about diseases such as multiple sclerosis or transverse myelitis, neuromyelitis optica. We think about different types of spinal cord compressions, optic nerve diseases, and we think about demyelination, axonal loss, axonopathies. And we want some way to characterize this pathology in a better way than does conventional MRI. So we'd like to look at myelin. We'd like to have a technique that's specific for myelin. But the reality is that there are challenges to myelin MRI. There are many methods that are available, but few are actually specific. A couple of ways to get access to myelin information would be myelin water imaging or magnetization transfer. So magnetization transfer is what we'll focus on today, and it may very well be a viable biomarker for myelin injury or repair. So just some quick basics so that we're all on the same page as we move through. The basics of quantitative magnetization transfer is that typically we think about having water that we would typically image with T2 or T1 weighted imaging, and we're sensitive to inflammation or water content change. There's a whole other subset of macromolecules or not water that's in the tissue that's intimately associated with the surrounding water. And these macromolecules, especially in the central nervous system, are unable to be imaged directly because they're short T2 on the order of microseconds. And we think there that that's where we get information about pathology. Due to the intimate communication between the protons that are associated with macromolecules and the surrounding water, we have some way to indirectly probe the macromolecular contents. An old slide from Peter Van Zyl many years ago sets this up a little bit. So how do we do a magnetization transfer experiment? The first thing that we do is we saturate the semi-solid component, and when we do that, that saturation is spread through the semi-solid component through spin diffusion very rapidly and saturating the protons that are associated with that. Those protons then exchange their information with the surrounding water and through a variety of different mechanisms, and that's what we ultimately image. So in vivo, what does this look like? We typically think about having a water component, a free water pool, and we also think about having a semi-solid proton pool associated with that. A typical magnetization transfer experiment that's been done for a number of years is that we would selectively saturate the solid phase protons. Those protons then would be exchanging, they are exchanged with the free water, but now they exchange the saturation and cause a reduction in the free water observation. When we do this in vivo, we show that here's a reference image, a so-called reference image. This is a non-magnetization transfer prepared sequence, and then we have our magnetization transfer weighted sequence here on the right. You can see that there's preferential darkening of the signal in the white matter, less so in the gray matter, and very little in the CSF. So we typically think that the primary source of contrast in the central nervous system of magnetization transfer comes from myelin and myelin-associated proteins and things of that nature. So when we look at white matter, we zoom in a bit, we see that we have axons surrounded by myelin. The myelin is actually a modified bilayer that is rich in cerebrosides and galactose head groups, and it's a modified bilayer in that there are many proteins that are associated with the myelin to keep it all together. And then when we zoom in a bit further on the cytoplasmic side, we had phospholipids, and on the extracellular face, we have glycolipids. And we think about this as the semi-solid phase. So recasting our original cartoon in terms of the biophysical model of MT, we have our macromolecular pool, which is thought to be closely related to myelin, and we have the free water pool that surrounds it, that's in exchange with that. So an experiment, we're going to recast it again for a third time just because I want to build into something that we can talk about as we move forward. We think about our macromoleculars being broad line shape, and we think about our free water being narrow line shape. A typical MT experiment would be the magnetization transfer ratio, which is the simplest experiment that we see and is performed in the clinic. Saturates the solid phase, causes a reduction in the free water, and we calculate the magnetization transfer as such. That is the reference image, the no saturation image, minus the saturated image divided by the non-saturated image. Now, there are many different ways to get access to magnetization transfer. Using sequences, we can use continuous wave sequences, a pulse train sequence, pulse saturation sequence, and basically what we're doing is we're trying to move from a continuous wave, which on human systems is not trivial because of the duty cycle of the RF amps, to something that's more feasible, more rapid, and can quickly provide magnetization transfer contrast. So again, conventional MTR, you saw this image a moment ago. When we calculate the magnetization transfer ratio, you see it here on the right. Now, the magnetization transfer ratio is related to myelin. It's sensitive to myelin changes. One of the quotes I heard many years ago is while magnetization transfer ratio may not be specific for myelin, what we understand is when myelin changes, so does the MTR. And we see this in patients with multiple sclerosis. And here we have a healthy control and an MS patient where you can see the paraventricular lesions here with a reduced magnetization transfer ratio. But the problem is the magnetization transfer ratio is not quantitative. It's sensitive to acquisition methods. It's sensitive to hardware designs. It's sensitive to vendor applications, the duty cycle of the RF pulse, and a number of other non-physiological parameters such as B0, B1, and it is sensitive to T1 relaxation, which has changed in many pathologies we know. So one thinks about how do we make this more quantitative? How do we make this to be a biomarker across multiple vendors, multi-site design, clinical trial, and be able to provide this as a longitudinal evaluation for patients with particular diseases? So we have to transition now to the idea of a quantitative magnetization transfer experiment. You saw this at the very beginning, which is the magnetization transfer ratio. We provide an RF irradiation. At 1 power, we saturate the solid phase. We have a reduction in our signal. Now let's turn our attention to quantitative magnetization transfer, where what we have is we have the same setup. We have the same model in the back of our head, although it's a bit simplified, certainly. And then with saturation-based quantitative magnetization transfer, what we do is we provide RF irradiation along multiple spots on the semi-solid line shape at many offset frequencies. And we sample this broad line shape in different ways. When we do this, we generate what's called an MTZ spectrum, which is a normalized signal as a function of offset, and we see the saturation spectrum here. When we go now back to our model, we assume that we have water and we have not water, so that not water is considered the macromolecular pool, and we can calculate the so-called pool size ratio, which has been shown as a marker for myelination, but it really is just the ratio of the free water to the the macromolecular water to the free water. Now, when we think about quantitative magnetization transfer, obviously we have to fit to a model, and fitting to cartoons doesn't always work, so we have to get into the math a little bit. And with saturation-based MT, what we see is a modified block equation that has components for exchange, shown in red, and saturation, shown in blue. And we can model the line shape. We've seen over a number of years the line shape of in vivo tissue would be something as a super Lorentzian, perhaps a numerical solution as well. But we can modify the block equations. We can fit those block equations to the Z spectra at multiple powers and offset frequencies and generate the pool size ratio. So here we show that PSR correlates with myelin content a bit better than does the MTR. And shown here a myelin percentage on the bottom and pool size ratio here on the left axis. It'd be the y-axis. And we've been able to validate this post-mortem brains to show the relationship between the PSR and the LFB staining in patients with MS, and show that there is a relationship between the PSR and the myelin there as well. Okay, So the first application, I promised in the talk that we would do a couple of applications. So we'll do one application, and then we'll move on to a different technique, and then we'll do another application. So the first application we want to talk about is multiple sclerosis. We know what multiple sclerosis is in this community. It's an attack of the central nervous system. It's autoimmune. It involves all of the CNS. So the optic nerve, the spinal cord, the brain. We know that it is characterized by axonal damage, myelination, demyelination, tissue atrophy. It's inflammatory. The disease course is transient. It's unpredictable. And it's difficult to design treatments that are effective at stopping and arresting MS over all patients. In some patients, some treatments work better than others. And in some patients, we have various courses. We know that MS has different subtypes, but I'm not going to go into that at all. But the short of it is that we know that it's characterized by myelin loss and, in some cases, myelin repair. When we think about radiological manifestation of multiple sclerosis, what do we think about? We know that we have paraventricular lesions, we have Dawson's fingers, we have contrast-enhancing T1 lesions that are also paraventricular. We know that for MS diagnosis, there has to be dissemination in time and space. So we have lesions on different hemispheres. And then when we know that MS is a systemic disease, we know it also affects the spinal cord. And we've known this for about 181 years, that there are lesions in the spinal cord in cases of MS, and we do see that indeed as well. So we'll start out with a tough case, but a case nonetheless that represents quantitative magnetization transfer, spinal cord. Here in the spinal cord, we have the white matter, and you can barely see the gray matter, butterfly-shaped pattern, the surrounding CSF. So we want to generate an MTZ spectrum like we would for any saturation transfer experiment, in that we have a low power, we have a high power saturation pulse performed at various offset frequencies. And we would sample this up to a certain area, a certain offset frequency where there's not as much saturation anymore. We fit this data to a model in a voxel-wise fashion. We correct for T1, B0, and B1, and then we derive a pool size ratio that comes from that Z spectrum. In the end, what that provides us is here's just an anatomical image showing the structures of interest, the gray matter butterfly-shaped pattern, and the surrounding white matter. And we have the pool size ratio shown here in controls and here in a patient with relapsing remitting. Now, I'll show you two of these because there has been a lot of work over the past few years at trying to streamline the analysis for quantitative magnetization transfer to use a single point method. The idea there is that a B0, B1, and a T1 corrected MTR experiment provides us with a good estimate of the magnetization, the QMT parameter of the PSR. So this is that here on the right side. You can see it smooths out some of the if you will, idiosyncrasies of the data, and it provides us still yet with the gray matter contrast, gray matter white matter contrast. In this particular patient, what we see is that the majority of the cord has low PSR in a patient with relapsing remitting, yet the ventral columns up here seem to be relatively normal. When we look at this over different subtypes of patients with MS, here again a healthy control. Here we see a patient with relapsing remitting with the dorsal column lesion shown by the arrow. We see that also in the anatomical image, and we see a reduction in the pool size ratio in the same area corresponding with that. In this same patient I showed you on the previous slide, this is a progressive patient with diffuse abnormalities throughout the cord, and we see again a diffuse reduction in the pool size ratio. When we look over multiple patients with multiple disease subtypes as well as multiple neurological impairment, what we see is that the MS patients in general have a lower pool size ratio than does healthy control. This is not unexpected. As I introduced the whole MT in multiple sclerosis paradigm, we said that MS is a demyelinating disorder. We said that magnetization transfer is related to myelin. Now I show you that in a demyelinating disorder, the pool size ratio is reduced. So this is not shocking or anything. There are some limitations to this, and this is, I call this originally conventional QMT, and I decided that's a bad word. There are limitations to saturation-based quantitative magnetization transfer, and some of the limitations are as such. We know that it requires additional measurements, B0, B1, and T1. I skipped through that very quickly, but we do understand that we need other measurements to characterize the Z spectrum. Co-registration is also an issue, especially when we move outside of the brain, when we want to perform QMT of the breast, of the liver, of the leg, and of the heart. But one of the challenges we have is with saturation-based QMT is that the power deposition for these saturation experiments is very high. The idea when we go from a continuous wave sequence to a pulsed sequence, what we do is we're generating a lot of tissue heating, a lot of power deposition because we're going very fast. And we can have things like a 1200 degree flip angle saturation pulse in a 50 millisecond TR, and we repeat this 400 times. So very quickly we accumulate power deposition problems, and this gets worse and worse as we move to higher and higher field. So there's some strategies that have been put in place. One that I want to focus on here because I think it's easy for us to understand is the selective inversion recovery method. And this is a QMT method that's based on a standard inversion recovery sequence. It alleviates some of these issues, but the interesting thing about the selective inversion recovery is that because it's an inversion, it has two fundamental benefits that we'll talk about. The first benefit I'm not going to spend too much time on, but because it's an inversion, I can tailor my inversion to be relatively B0 and B1 insensitive. So when we think about 70, when we think about outside the brain where susceptibility becomes a problem, I can tailor a sequence, especially with multi-channel design, to be able to mitigate many of the power deposition problems, the B0 problems, and even the transmit field and homogeneity. A lot of times, though, inversion recovery scans take a long time, and this is something that we know requires optimization for clinical application. So selective inversion recovery sequence, we have our same mental model here of the solid phase protons, and we have the free water. And typically with the saturation-based method, we would provide an RF irradiation off resonance with respect to water. In the selective inversion recovery, we do an on-resonance inversion. We invert our water signal, and then we watch it recover. In a case where we have free water, or we have just a bucket of water, we would expect a typical inversion recovery curve that can be modeled by an exponential recovery. However, when that water is in exchange with macromolecules, we see that this is no longer a single inversion, or as I should say, a single recovery, but actually there's a bend in it. And this can be modeled through this expression here. And one of the things that we can calculate is we can still calculate the pool size ratio and the ratio of the coefficients of the exponents. But the other thing that is important, because this is an inversion recovery pulse, we get two free measurements. We get a T1 measurement that just comes as a result of fitting this to a single exponential recovery. We also get a measure of B1, because that tells us something about the efficiency of the inversion that we expect. So we get two freebies in the selective inversion recovery that we don't get in the saturation method. And typically this is done, we have an inversion pulse, we wait a particular inversion time, and then we provide some sort of fast spin echo readout. We can do a number of other types of readouts, which I'll show you shortly. And you can see here the images on the right, the brain at a 10 millisecond all the way through a 2000 millisecond inversion delay. This looks like a flare, this looks like a spin density, and we have some contrast, maybe an MP range there in the middle. So here I show you a case in the brain with patients with multiple sclerosis. Again, we see the Dawson's fingers and paraventricular white matter abnormalities on the flare in T2, and we have the magnetization transfer ratio, which is abnormal, many of us would say. When we calculate the pool size ratio from the selective inversion recovery, we see that in general, the white matter has lower pool size ratio compared to the healthy control, and we do see lesions in various areas. Difficult to see maybe from the back of the room or from the far side of the room, but these lesions also show up on the R1 map. That comes for free. So we have to speed this up. One way to do this is through pulse sequence design. And I'm not going to belabor this, but we can think about ways to create reset pulses, to have saturation trains that continue to flip the magnetization around so that we don't have to wait as long for T1 recovery. And here shown three, an EPI readout as opposed to a fast spin echo, basically an MP rage type sequence, and then a fast spin echo here. So the interesting thing is that because it's an inversion pulse, I told you the first thing is that we can tailor it for use at any field strength because we can design a pulse that's B1 and B0 insensitive. But the other thing is, because it's an inversion pulse, we have many inversion type sequences that we're really happy with in the clinic. We think about STIR, short tau inversion recovery, MP rage, flares. We do many types of inversions, so we're comfortable with that. And you can couple this type of inversion pulse with an MP rage type readout. So instead of MP rage, call it a SIR rage, and get the scan time down pretty quickly for whole brain coverage. And indeed, this is something that can be applied in the clinic. This is applied at the hospital at Vanderbilt. And we see, again, patient with MS. We have paraventricular lesions. We see some chronic black holes on T1. And then we see that there's a reduction in the pool size ratio here, as well as correlation with age and duration of disease and disability as well. In typical, again, I said that we could use this to, the inversion pulse to be able to combat the B0 and B1 homogeneities at higher field. This is a study that was done to look at the QMT and gray matter and as it relates to cognition in patients with MS, and this was done at 7 Tesla. And we didn't have any SAR concerns there, and we're able to tailor it to get uniform inversion. And we show, again, a lot of data here. I don't want to go through all of it, but we do show that there are correlations with various components of the disability score as well as cognitive performance. The second application that we study at Vanderbilt and many other applications, but I kind of want to highlight this one, is looking outside the brain at Charcot-Marie tooth disease. This is inherited peripheral neuropathy. It's fairly rare, but it creates a long-standing disability over the course of years. It's a motor sensory impairment, and it's typically length dependent. So one of the challenges there is that we know that it is a de- or dysmyelinating condition, and it's typically length dependent. So what that means is that the further we get down the leg, the more difficult it is to measure with typical probes. And we use conductance measures, but as we know in a length dependent disease, the conductance measures don't work very well. So we need something that assesses the myelination in a length dependent fashion and provides a readout for Charcot-Marie tooth disease. And many other diseases. Again, we can consider diabetic peripheral neuropathy. We could think about optic neuritis. We could consider many other conditions there. So magnetization transfer in sciatic nerve and a lower CMT. So this is a control. You can see here the sciatic nerve. So this is in the upper leg above the knee. We can see the sciatic nerve here, and then we can see two things. We can see a bigger sciatic nerve, in this case in the Charcot-Marie tooth disease, but also reduced ratio in the nerve there. We know that even the magnetization transfer ratio varies across subtypes, and we have similar experience with pool size ratio showing that it indeed varies in a similar fashion. So these subtypes, I'm not going to go in, some of them are primary demyelinating, some of them primary axonopathy with secondary demyelination, and some of them are swollen type nerves as well. We show that it relates to disability as well. And again, I said we do QMT in Charcot-Marie tooth disease. Same information below, but just to show you that what the leg and sciatic nerve looks like and the fit to such a model in the sciatic nerve. The sciatic nerve is only about 5 millimeters across, so we can tailor this for higher and higher resolution as well. And in particular, the PSR is able to discriminate between patients that have mild, shown here with less than 10. This is a neuropathy score, discriminate between mild patients and patients who are a bit more severe. So in summary, I've spent long enough with you this morning. I do certainly appreciate your attention as we go through this, but I hoped I was able to talk a little bit about the MT phenomenon, then introduce the idea of QMT, quantitative magnetization transfer, based on the models that we have. I did not go into the complexity of the models. We could be here for 6 or 7 hours, and I'm happy to talk to you about this afterwards, but there are many models that are proposed. There are many types of analyses that could be deployed, and this was more of an opportunity to just provide an overview of what we looked at. We showed a couple of applications in spinal cord, brain, multiple sclerosis, Charcot-Marie tooth disease. Again, this is not meant to be an exhaustive comparison. There are hundreds of applications and hundreds of opportunities for each one of us to explore magnetization transfer. I didn't talk about any applications really in the body or other neurodegenerative diseases like Parkinson's or Alzheimer's disease. I didn't talk about cancer at all. I didn't talk about the advanced models. I didn't talk about inhomogeneous magnetization transfer, or CEST, as well. But I hope that we're able to at least cover a little bit of ground and set the stage for more conversations after this as well. There are many, many people involved in the lab and in the workup on some of these techniques. Certainly want to thank the collaborators in neurology who provide patients and constant support, everyone in my lab at the Imaging Institute as well, and the many grants that go into supporting the work that was presented here as well. And with that, I'm happy to close and take any questions that you may have. Thank you.